Hi there, I'm Jonathan Zor with the Virginia Center for Inclusive Communities. At VCIC, we're committed to supporting an equitable and inclusive response to the COVID-19 pandemic, and we're so fortunate to be connected with leaders across Virginia who share in that commitment. Since 1963, VCIC has recognized individuals and organizations with the Humanitarian Award, our highest honor for those who advance understanding and respect in Virginia. Through our Humanitarian Spotlight series, I'm interviewing past Humanitarian Award recipients who are demonstrating important leadership in response to the COVID-19 pandemic. Today, I'm honored to be joined by Dr. Michael Gillette, a 2006 VCIC Humanitarian Award recipient from our Lynchburg chapter. Dr. Gillette is founder of Bioethical Services of Virginia, which serves a wide variety of organizations primarily within the healthcare industry. He's taught at colleges and universities and published articles in the field of clinical ethics. Dr. Gillette was elected 3 times to the City Council in Lynchburg, Virginia, and he served 2 terms as Lynchburg's mayor. Dr. Gillette, it's so good to chat with you today.
Good to see you.
Good to see you. I wonder if you can start off by sharing some of the major ethical issues that you're seeing in the midst of this pandemic.
Wow. There is a very long list of ethical issues that are coming up in response to the pandemic, and they really range from the broad societal questions to organizational specific issues. So we certainly have seen on the federal level and the state level and even the regional level, questions come up about how services should be coordinated, how resources should be distributed, whether or not organizations have a responsibility to cooperate with one another. Those are pretty high level questions, but then I've also been spending a lot of time consulting with individual organizations to help them develop policies, again, more locally on distribution of resources, some of which are pretty intense discussions, but also talking about autonomy issues, liberty issues. The range of questions just is immense. And I've been excited lately in sort of an unhappy way to be able to help with so many different policy issues and ethics consult issues that have come up.
Yeah, the range is huge to your point, whether it's an organization or a college or university or medical facility. One of the things we're seeing at VCIC and hearing about is disproportionate impact depending on a person's identity. So the quality of care you'd get in a medical facility might be different based on your race or class or age, your experience applying for a loan, for example, in the banking industry. Are you seeing some of those things, and what should we be considering around the diversity and inclusion or equity issues here?
I think that there are probably 2 answers to that question. The one that I think you've touched on first has to do with how the contagion spreads differently in different populations, or how different individuals are able to respond, or what sort of access they have to healthcare. In that regard, I honestly have to say that I don't believe that COVID-19 is causing any of those issues. In other words, I have not seen that hospitals are making overtly discriminatory decisions about whom they will treat or whom they will not treat. But what I do think is clearly the case is that this pandemic experience has revealed the inequities that were already inherent in our healthcare system. So, for instance, if the African American population is seeing disease rates at a much higher level, and they're seeing death rates at a much higher level, I don't necessarily think it's because the hospitals are deciding to treat them with a lower standard of care now. I think what that means is that populations within our society have historically been disenfranchised with regard to access to healthcare, and not just healthcare, but quality of life in general. Poverty is an incredible indicator for secondary conditions that could complicate something like being COVID positive. So I think what you're seeing is that rather than the coronavirus causing new types of discrimination in an overt way, I think what it's really doing is ripping off the mask and showing us that there have been extraordinarily disparate experiences in terms of individuals' ability to access good food, to remain healthy, to have good relationships with primary care physicians, so that when they face something like this, they are in the best possible health condition in order to survive. Now, there is a secondary answer to your question that might be a little bit more pointed. One of the things that I've had to do lately, which I really thought I would never do, was to develop policies on ventilator triage. Now, I've done a lot of work on allocation of scarce resources throughout the years. We have a lot of experience deciding, say, who gets the one kidney that's available when 5 people need it. So allocation of scarce resources is not something new. I've done a lot of work on that. But we are now pressed to the point where we're not just deciding if 2 people show up both in need of a resource, and there's only one of that resource available, who should get it. We're now getting to the point where we're asking ourselves, if someone shows up in need of a resource and someone else is already using the resource, should we strip it away from the person who's already using the resource in order to liberate it for a new patient who might have a higher likelihood of survival? We generally don't take people off ventilators in order to make space for new patients. We don't, for instance, take away a kidney from someone in order to give it to someone who has a better chance of survival. So this is really pushing allocation issues to the absolute ethical maximum. And that might be a place where you're actually seeing much more overt discrimination, although it's not necessarily on the basis of race. Race could be a secondary factor if race also impacts general survivability. But now we're seeing discrimination on the basis of age. We're seeing discrimination on the basis of other disease factors that are not COVID-19 relevant. For instance, people with a history of serious mental illness in some of the protocols that I have read are ruled out for intubation, for being placed on a ventilator. Individuals with intellectual disabilities or individuals with dementia. So we're beginning to see a softening of the expectation that when a healthcare provider meets a patient and makes decisions about the provision of care, that should be done without making any social worth or moral worth judgments about the recipient of care. I am very concerned that if we begin down that slippery slope and we start saying, well, 30-year-olds are just more valuable than 60-year-olds. Or people with mental illness are sort of marginal anyway, so we need to save more productive members of society. I'm very concerned that if we take that step, that it will be very, very difficult to determine where that slide ends. And we could be making decisions based on social criteria. In other words, how much does this person feel like me, look like me? How much sympathy do I have for this individual? Do I think this was their own fault? After all, they engaged in risky behaviors and they didn't have to. Those sorts of social and moral judgments are very dangerous in the context of medicine. And we are being forced to make very, very hard triage decisions. So I'm concerned about that. And in fact, I'm proud to say that with one of the hospitals that I work, where we wrote that policy, we were explicit in saying, if there is not a demonstrable link to an objective healthcare factor, we will not be making social and moral judgments when we determine who receives and who does not. But that's not consistent across the country. There are many model policies out there that take into account even things like family status. So if you have children, dependent children, you get a ventilator before someone else who doesn't. Think about the indirect influence that would have on different demographics and whether or not that inadvertently advantages some and systematically disadvantages others. Those are things that I'd be very concerned about.
You've introduced a wide range of considerations for the healthcare field, and it's certainly a significant concern that there aren't consistent policies like the one that you recommended. For those who are watching this who may not be in those decision-making platforms or have that platform, but are still having to make daily decisions that may affect other people, what are some of the ethical considerations for just a person in Virginia who's wanting to do the right thing right now?
Well, I think it's very important that that person in Virginia be thinking to him or herself, I want to do the right thing. In other words, they're trying to figure out what the right thing is, because I am concerned that there are many folks who, when they answer the question, what's the right thing for me to do, they understand that question only as far as it goes to their own health. So they're thinking, well, if I'm young, if I'm healthy, if I don't have a complicating condition, well, I'm willing to take a risk. You know, I feel like in order to get back to something like normal, I'm willing to, maybe I'll wear a mask, maybe I won't, because you know what? It's up to me to decide how much risk I am willing to tolerate. I think that that is a huge mistake when we think about the ethics of doing the right thing in the midst of a pandemic. Your behaviors don't impact only you. And so when you want to ask what it means for you to do the right thing, you have to be taking into account not just what your health risks are, but the health risks that you're subjecting your neighbors to. And you may not know their whole stories. They may be immunocompromised. They may be taking care of someone at home who's immunocompromised. And so when you meet them out in public, they may look perfectly healthy to you, but interacting with them in a dangerous way could have ripple effects that are just unacceptable ethical consequences. So people really need to be careful. It's not about how much risk you feel comfortable accepting in your own life. It really is finding, I don't want to say it this way because it sounds pejorative, but I'll use the term anyway, the lowest common denominator. In other words, the weakest person in the chain. We need to protect the most vulnerable among us. And we don't do that if the only calculus that we are making is how we feel ourselves about being at risk.
Absolutely. Thank you. It's a great point for us to end on. Dr. Michael Gillette, I'm so grateful to you for sharing your expertise and your time with us. And we're so fortunate at VCIC to count you in our community of supporters. I hope you continue to stay safe and well.
Thank you, and I wish the same for you and everybody who watches this. If you're out there doing first responder work or stocking shelves, or if you're a hospital employee, if you're doing any of the important things that society needs that don't allow you to stay home, thank you, thank you, thank you. Stay safe, stay well, and we'll all get through this.